J point and J wave. The J point is the junction between the termination of the QRS complex and the beginning of ST segment. J point or junction point in ECG is the point where the QRS complex joins the ST segment. It represents the approximate end of depolarization and the beginning of repolarization. The J point marks the end of QRS complex and is often situated above the baseline, particularly in healthy young males. The J point may deviate from the baseline in early repolarization, epicardial or the endocardial ischemia or injury, pericarditis, right and left bundle branch block, right and left ventricular hypertrophy, or digitalis effect. How to recognize the J point? As we know, the QRS complex represents the ventricular depolarization. Depolarization means the cells becomes electropositive. The depolarization of ventricular cell is sodium dependent. Q wave is due to the septal depolarization. R wave is due to the major ventricular depolarization, and the S wave is due to the depolarization of basal part of the ventricles. When the positive charge of the depolarization wave moves towards the electrode, it causes the positive deflection, and when it moves away from the electrode, it causes negative deflection. At the end of the depolarization, when all ventricular cells becomes depolarized and just before the repolarization starts, all the cells becomes electropositive, thus there is no net movement of the current through the ventricular cells. This represents the ST segment. As there is no electrical movement, this ST segment becomes isoelectric. Thus the J point is the end of the QRS complex and the starting of this isoelectric line. That means the ST segment. So the J point in ECG would be after the QRS complex, and after this point there would be one isoelectrical line. Abnormalities of J point. Elevation or depression of the J point is seen with various causes of ST segment abnormalities. It may be elevated as a result of injury currents during acute myocardial ischemia or pericarditis, as well as in various other patterns of both normal and abnormal ECGs. Elevation of the J point occurs with benign early repolarization. Benign early repolarization producing widespread ST segment elevation with commonly seen in young and healthy patients less than 50 years of age. It may mimic pericarditis or acute MI. ECG features are generalized concave ST elevation in precordial leads V2 to V6 and the limb leads 1, 2, 3 AVF. J point notching is evident in the inferior leads 2, 3 and AVF, and ST elevation T wave ratio less than 0.25 in V6. A positive deflection prior to the J point is termed as J wave and is characteristically seen with hypothermia. The letter J in the ECG defines two totally different and unrelated events. The J point is a point in time marking the end of QRS and the onset of the ST segment, present on all ECGs. And the J wave is much less common, long slow deflection of uncertain origin, originally described in relation to hypothermia. The Osborn wave, J wave, is positive deflection seen at the J point in precordial and true limb leads. It is most commonly associated with hypothermia. These changes will appear as a reciprocal negative deflection in AVR and V1. The causes of Osborn wave characteristically seen in hypothermia, but they are not pathognomonic. Causes of non-hypothermic Osborn waves include hypercalcemia, acute myocardial ischemia, left ventricular hypertrophy due to hypertension, Takotsubo cardiomyopathy, normal variant and early repolarization, neurological insults such as the intracranial hypertension, severe head injury, and subarachnoid hemorrhage, severe myocarditis, Brugada syndrome,